Patient-reported outcome instruments in glaucoma surgery. Glaucoma surgery can lower eye pressure and slow vision loss, but patients care most about how their vision and daily life feel afterward. Patient-reported outcomes capture what matters to patients. For example, how well they see, whether their eyes feel dry or irritated, and how easy it is to manage treatment. To understand these effects, researchers use questionnaires and surveys. Common vision-related questionnaires include the National Eye Institute Visual Function Questionnaire 25, NEI VFQ-25, and glaucoma-specific tools like the Glaucoma Quality of Life-15, GQL-15, which ask about difficulty with reading, driving, and performing everyday tasks. Ocular surface symptoms, dryness, burning, grittiness, are often measured with tools such as the Ocular Surface Disease Index, OSDI. Treatment burden and convenience can be assessed by treatment satisfaction surveys. For example, the Treatment Satisfaction Survey for Intraocular Pressure, or newer instruments like the Allergan Satisfaction with Treatment Experience Questionnaire. And some glaucoma-specific instruments now include treatment convenience or ocular comfort domains. For instance, an adaptive GlaucomaCAT tool, GlauCAT, measures 12 domains of glaucoma quality of life, including visual symptoms, ocular comfort, and general convenience. These validated PROMs ensure we listen to patients' perspectives after surgery. Quality of life after different glaucoma surgeries. Glaucoma procedures vary widely in their effectiveness and recovery, and this shows up in patient-reported outcomes. Minimally invasive glaucoma surgeries, MIGS, often done at the same time as cataract surgery, tend to have a modest pressure-lowering effect, but a gentle recovery. For example, one study of patients receiving combined cataract surgery plus a MIGS device, hydrus or eye stent, found significant improvements in patient-reported visual symptoms, ocular comfort, and general convenience. These patients also used fewer glaucoma eye drops after surgery. An average drop count fell from about 1.8 to 1.1 and showed better tear film tests on exam. In other words, by relieving pressure and clearing the vision from the cataract removal, MIGS patients reported better vision-related quality of life and fewer symptoms of dry or irritated eyes. In contrast, traditional filtering surgeries, trabeculectomy, making a new drainage channel, and glaucoma drainage implants, tube shunts, usually achieve greater pressure reduction and bigger drops in medication. These bring their own trade-offs. Trabeculectomy often eliminates or greatly reduces the need for daily eye drops, but it involves a longer healing course and possible side effects, e.g. low pressure, blood management. A large UK trial, TAGS, found that 2 years after surgery, patients who had trabeculectomy used about 1 drop per day on average, versus about 1.6 drops in patients managed with medications only. However, the same trial showed no significant difference in overall vision-specific quality of life, NEI VFQ-25 scores, between the surgical and medical groups up to 24 months. In clinical practice and smaller studies, patients who undergo trabeculectomy often report more eye irritation, redness, foreign body sensation, and longer periods of blurred vision than those having MIGS, IGS, or simpler procedures. For example, one study found that about 1 to 2 weeks after trabeculectomy, many patients still needed patching or activity restrictions, and vision could remain blurry for up to 6 weeks. Comparisons among surgeries have shown meaningful differences. In one quality of life survey comparing trabeculectomy versus non-penetrating canaloplasty, canaloplasty patients reported higher overall satisfaction and mood, and far fewer non-visual symptoms, like glare, burning, or stinging, than trabeculectomy patients. Importantly, daily activities, reading, driving, socializing, were much less disrupted after canaloplasty. Patients rated interference almost non-existent, while trabeculectomy patients often needed longer recovery. A small study of MIGS versus trabeculectomy found no significant difference in quality of life scores at 6 months, but the trabeculectomy group did achieve lower pressures and larger medication drops. Glaucoma drainage implants, tubes, have a different PRO profile. Patients typically experience a slower functional recovery and more discomfort than trabeculectomy patients. One study using daily diaries reported that tube shunt implantations caused greater short-term post-op difficulty than trabeculectomy, and both glaucoma surgeries had a slower recovery of function over the following weeks compared to routine cataract surgery. Tube patients often continue some drops afterward and may worry more about future surgeries, but objective QOL measures, NEI VFQ-25, tend to be similar between trabeculectomy and tube in cross-sectional studies. In summary, MIGS tend to give patients a quicker, more comfortable recovery with fewer symptoms, especially when combined with cataract surgery, at the cost of somewhat less dramatic pressure lowering. Trabeculectomy and tube shunts offer powerful pressure control and often eliminate eye drops, but with longer downtime, monitoring, and more eye irritation in the short term. Canaloplasty provides good pressure control with a very patient-friendly profile, no bleb, minimal symptoms. These differences in recovery and comfort are important for patients to understand when choosing a surgery. Linking clinical outcomes with patient experience. Clinical measures, eye pressure, visual acuity, visual field tests, do not tell the whole story of how patients feel. Several studies have explicitly linked patient-reported outcomes to these clinical changes. For example, after MIGS with cataract surgery, improvements in patient-reported visual symptoms and ocular comfort were driven largely by measurable gains, specifically the better eye's visual acuity from the cataract removal and lower intraocular pressure. In other words, when the cataract was cleared and pressure came down, patients reported less blur and dryness. Even so, recovery of daily function, answering how soon patients can read or drive, can't be fully predicted by vision or pain alone. In a study tracking daily recovery, researchers found that after cataract, trabeculectomy, or tube surgery, early post-op vision and pain only partly explained how patients rated their functional ability. Patients still felt limited in activity, even when acuity had returned or pain was gone. This implies that asking patients directly about their daily activities is crucial. It uncovers issues that eye charts and pressure gauges miss. For shared decision-making, clinicians should discuss outcomes that matter most to patients. Qualitative studies consistently show patients care about practical vision goals, being able to drive, read fine print, see at night, and about treatment burden, how many drops they must use, eye discomfort from medications or surgery. For instance, in interviews, patients often spontaneously mentioned that continued need for eye drops was inconvenient and that they feared not being able to read or see well while driving at night. These patient-derived priorities suggest that, when choosing a surgery, doctors should explain not just the expected pressure drop, but also how vision for daily tasks and comfort in the eyes are likely to improve. For example, MIGS plus cataract surgery may not lower pressure as much as trabeculectomy, but it often clears up vision from the cataract and lets people use fewer drops. Trabeculectomy might mean months of careful follow-up, patches, adjustments, but can eliminate most medications. Together, patients and doctors can weigh these trade-offs based on what the patient values: medication freedom, clear vision, fast recovery, or maximal pressure drops. Gaps in long-term PRO data and future directions. Despite growing interest, long-term patient-reported data on glaucoma surgeries are still limited. Many studies follow patients only a few months after surgery. For example, recent data on MIGS quality of life improvements typically extend only 6 to 12 months follow-up. Longer-term outcomes, years after surgery, are largely unknown. It will be important to study whether early PRO gains, like improved comfort and independence, persist over time and how they relate to maintaining vision years later. Another gap is consistency of measurement. There is no single standard PRO instrument for glaucoma surgery, and studies use a mix of general and disease-specific tools. New instruments like the GlauCAT, computerized adaptive testing, show promise by covering many vision and comfort domains, but they need more validation in diverse populations and different surgical contexts. Notably, most validated PROMs have been developed or tested in certain regions, so we need more data in underrepresented groups. Moreover, few randomized trials of glaucoma surgery include PROs as core endpoints. For example, MIGS trials focus on intraocular pressure and visual field outcomes without fully capturing how patients feel or function. Future research should include PRO measures, vision questionnaires, symptom scales, convenience or satisfaction surveys in surgical trials and registries, Follow patients for years rather than months, compare PROs across different surgery types, and involve patients in defining what outcomes matter. As one expert group notes, clinical trials should reach beyond pressure and field tests to include patient-centered outcomes like treatment burden and quality of life. Filling these gaps will help surgeons and patients make truly informed, shared decisions about glaucoma surgery. Conclusion: in glaucoma care, patient-reported outcomes add vital context to clinical measures. Questionnaires like the NEI VFQ-25, GQL-15, OSDI, and newer satisfaction and convenience scales have been used to capture how surgery affects day-to-day vision, eye comfort, and treatment ease. Studies show that minimally invasive procedures, often with cataract surgery, tend to improve patient comfort and reduce drop burden more quickly, while traditional surgeries achieve greater pressure reduction, but with longer recovery and more irritation. Linking PROs to exam results reveals, for instance, that clearing a cataract, improving visual acuity, and dropping pressure correlates strongly with better patient-reported visual function and comfort. Considering PROs is essential in shared decision-making. Patients prioritize vision for activities, driving reading, ocular comfort, less tearing or burning, and simplicity of treatment. Clinicians should discuss how each surgical option may affect these factors, as well as the usual clinical targets. In the future, eye care research should collect more long-term PRO data and refine tools to ensure every patient's voice helps guide glaucoma treatment. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.